All right. Yeah. Thanks, everybody. And depending on where you are, it might be afternoon, or for my South African colleagues, it's in the middle of the night. Um, so this evening, I'm presenting on overall and cause-specific mortality and associated risk factors among middle-aged and older rural South Africans. And this is findings from the Health and Aging in Africa, a longitudinal study of an in-depth community in rural South Africa from the HAALSI study, which is a collaboration between University of Witwatersrand and Harvard. Yeah. All right. So as a way of introduction, it is common knowledge that mortality is influenced by an interaction of a range of factors, which consist of demographic factors like age and sex, as well as lifestyle factors, living arrangements, and the environment, as well as healthcare systems. And these factors either reduce or increase the susceptibility of individuals to various diseases and subsequent mortality, either independently or jointly. However, the effect of various factors on mortality vary across settings or within the same setting, also varies across time. And this is mainly because of differences in broader demographic, socioeconomic, technological, political, cultural, and the effect and cultural factors. So it is important that mortality levels and death profiles and their risk factors should be assessed on continuous basis in order to improve our population health. So in this work, we aim to examine risk factors for overall and cause-specific mortality in adults aged 40 years and older in a rural South African setting. The setting is the one that has already been described from some of the previous presentations. It's in Agincourt sub-district, which is in rural northeastern part of South Africa, closer to the border with Mozambique. The setting is underpinned by a health and demographic surveillance platform that was established in 1992 and currently follows a population of about 116,000 individuals in 31 villages. And a third of this population is former Mozambicans, and the population is characterized by high levels of unemployment and also high levels of secular labor migration, where people move to urban areas to look for employment. And the infrastructure is poorly developed with poor water supply and sanitation in the area. So we use the data from the HAALSI study, which was collected in 2014. HAALSI has collected data now. There's been 4 waves, but we're using the first wave. And when these individuals were sampled from the Agincourt surveillance population, and we have been followed until 2021 to ascertain who died and who was still part of the cohort. And that's the data that we use to estimate overall mortality, but also within the Agincourt surveillance, we also conduct verbal autopsy interviews for every death that has been observed, and we use this information to assign causes of death. The process of assigning the actual causes of death, we used inter-VA and the in silico computer algorithms, and unlike other approaches which use doctors' assessments. We use survival analysis, and also we use Cox proportional hazard models to assess the association between mortality and various risk factors. and we used the final grade computing risk proportion hazard models in the cause-specific mortality analysis. Okay, some results. So in terms of the actual mortality, by 2021, we had observed about 22% of the cohort had died. That's about 1,116 individuals. And you can see in terms of the mortality by the different characteristics that were measured during the baseline in 2014 and 2015. One of the things that we observe is most of the deaths occurred among people with hypertension and diabetes, as well as HIV, but also people in the advanced age groups. In terms of risk factors for overall mortality, so these are age and sex adjusted. In terms of age and sex, as I've said, mortality is higher among people with very advanced ages, but also we see the normal differential between males and females, that males, they have higher mortality at each successive age group compared to females. In terms of the actual risk factors, what we find a number of self-reported as well as objectively measured characteristics that are associated with mortality, and these include activities of daily living, work time, grip strength, a history of diabetes. Actually, this is measured diabetes, a history of tuberculosis, and also HIV, especially people that are HIV positive and they have an unsuppressed viral load. In addition, religion also showed to be associated with the risk of dying, marital status, as well as history of smoking, and the more profound self-rated health. So people that rated themselves as having poor health, they had elevated risk of dying. However, deaths are distributed by cause. We see that most of the deaths they were caused by cardiovascular diseases. More than like about a third of the deaths, about 30%. And this is just comparing the two methods that we used in the VA and in Silco VA. There are some differences, but not really significant differences in terms of how these two algorithms are assigned the causes of death. So going forward, we just pick one of the methods. So we pick the in silico VM method for the next set of analysis. In terms of so this is what I've just alluded to in terms of the distribution. Mostly is cardiovascular causes, about 30%, and then followed by other infectious causes, and also we also see a significant proportion of these deaths being caused by cancers and other NCDs. By age, what we see is the contribution of HIV starts reducing with age. As we go to the older ages, we see the dominance of cardiovascular, respiratory, and metabolic diseases as the main causes of death. Lastly, looking at the age-specific mortality risk by age, cause-specific mortality risk by age, we see that there isn't really much of a difference for HIV, but we see a difference in terms of other infections and also the cardiovascular diseases that they increase with age, and also the cancers they increase with age. Same with the metabolic causes, and then also the other NCDs. And this is the same for both males and females. Of course, once we split between males and females for some of these causes, then the numbers are very small. That's why we see very wide confidence intervals. So in terms of what are the key findings? So we find that multiple risk factors consisting of demographic, socioeconomic behavior, and health status are related to overall mortality among these middle-aged and older adults in this rural South African setting. And also we see that the cause of death profile is highlighting the prominence of mortality burden from cardiovascular diseases, and also cancers alongside the persistent burden from HIV, TB, and the other infectious causes. Yeah, so that's concludes, and thanks to our different partners, various partners in the US, as well as in South Africa, and also our funders. Thank you.